Hello, this PowerPoint presentation is on opioids. Analgesics and opioids. Analgesics are drugs that relieve pain without causing loss of consciousness, and opioids are the most effective pain relievers that we have available today. An opioid is a general term that is defined as any drug, natural or synthetic, that has actions similar to those of morphine, where opiate applies only to compounds present in opium, the plant. Opioid receptors, you have three main classes: the mood receptors, the kappa receptors, and the delta receptors. The mood receptors are the major ones that we look at usually when we think of opioid pain medications and where they have their mechanism of action. You now have agonist, antagonist opioids, and buprenorphine would be an example of that type, the Suboxone. Um, when administered alone, they produce an analgesia. If administered with a pure opioid agonist, they can antagonize analgesia caused by the pure agonist. That's why it's important when we're using buprenorphine as a alternative to opioid use for addiction, that the patient must not be also still trying to take their illicit street drugs. Pure opiate antagonists are naloxone or Narcan, which is a prototype of pure opioid antagonist. Antagonists work at the mu and the kappa receptors. They do not produce analgesia or any other effect caused by opiate agonists. They can help with reversal of your respiratory and central nervous system depression caused by an overdose. And they also come in a few forms that help to treat the opioid induced constipation. This is mainly why they are now giving the Narcan pens to heroin addicts or opioid addicts in case there is an overdose, so that if someone that's with them can administer the Narcan for the overdose. What are the basic principles of pharmacology for opioids? The strong opioid agonists are morphine and others, which we'll discuss. There are moderate to strong opioid agonists, and there are agonist antagonists. So first we're going to talk about morphine. Morphine is from the seed pod of the poppy plant, so it is a natural product. Overview of its pharmacologic actions: it can relieve pain, it can produce drowsiness, it can cause mental clouding, it can reduce anxiety, provide a sense of well-being, it can cause respiratory depression, constipation, urinary retention, orthostatic hypotension, emesis, meiosis, cough suppression, biliary colic, tolerance, and physical dependence. What is the therapeutic use for morphine in its relief of pain? It relieves pain without affecting other senses such as sight, touch, smell, and hearing. There is no loss of consciousness, as it would be with how people have taken propofol, which would make them lose consciousness. And it can relieve pain by mimicking the actions of the endogenous opiate peptides, primarily at the mu receptors. What are the adverse effects? Well, there's respiratory depression, with the very young and the very old being the most sensitive to that. Onset is very quick, with intravenous is 7 minutes, with an IM 30 minutes, sub-Q up to 90, and it may last for 4 to 5 hours. There's also spinal injections where the response may be delayed by few hours so that it is used in those blocks, they're blocks that are given to help relieve back pain because they can last for quite a while for a patient when they receive those. Um, there can be tolerance to respiratory depression can develop, but that doesn't mean that it won't still happen. And that's why many patients that are doing opioids are, especially if they're also taking alcohol or other drugs, um, will seem fine, and then they will go to sleep later on. Could be that night, the next day, and not wake up. There can be increased depression with concurrent use of other drugs, of course, and it can compromise the patient with impaired pulmonary function. So, especially if the patient already has asthma or COPD, or they are extremely obese. Another adverse would be constipation, and it's caused by suppressed intestinal contractions and increased tone of the anal sphincter with inhibited secretion of fluids into the intestinal lumen, which of course help for the stool to be soft enough to pass. Complications of that constipation include fecal impaction, bowel perforation, rectal tearing, and hemorrhoids. Treatment includes physical activity, increase intake of fiber and fluids. A stimulant laxative may be needed, stool softeners. Um, Orthostatic hypotension. Morphine-like drugs lower the blood pressure by blunting the baroreceptors and dilating peripheral arterioles and veins. So for patient teaching, they need to know the symptoms of hypotension, which could be lightheaded and dizziness, and instructions to sit or lie down if they occur. Hypotension can be minimized by moving slowly when changing from a supine to a seated, then to an upright position. Urinary retention and hesitancy may also be a problem due to changes in the tone within the bladder. Another effect is cough suppression. The opioid receptors in the medulla suppress cough, and suppression of spontaneous cough may lead to accumulation of secretions in the airway. So it's not the kind of cough suppression you would think as codeine provides when you have a bad cough with a cold. So patients should be instructed to actively cough at regular intervals. There can be biliary colic, which induces spasms in the common bile duct, which will lead to epigastric distress and biliary colic. And this may be intensified. Emesis may be another problem, and it's caused by the nausea and vomiting through the direct stimulation of the chemoreceptor trigger zone in the medulla. We find that the urge to vomit is greatest with the initial dose. It decreases with subsequent doses, and that patients that are lying down have much less nausea and vomiting than those that are ambulatory. So one remedy is to have the patients lie down and then also pre-medicate with a antiemetic um, to relieve those symptoms. And it's important to tell patients that a symptom of emesis is an adverse reaction. It is not an allergy. I often have patients that say they're allergic, and when you ask them what happened, they'll say, oh, it made me throw up. But that's not necessarily an allergic reaction. It's an adverse reaction, especially if it's not accompanied by any other signs that would indicate it's an allergic reaction, such as a rash or any kind of swelling in the tongue or lips. There can be elevation of intracranial pressure, but that can be avoided by um, maintaining a good respiratory rate. There can be euphoria or dysphoria, and euphoria, of course, is an exaggerated sense of well-being. Dysphoria is a sense of anxiety and unease. Dysphoria is uncommon in pain patients, but may occur when morphine is taken in the absence of pain. So those that are abusing morphine may have that sense of dysphoria. And I've seen that in practice where patients are anxious and they just don't even seem to know why. Another issue is sedation. There can be drowsiness, there can be mental clouding. Patients need to advise not to operate heavy equipment, not to drive when they're taking these meds. Even though you'll find that patients that are taking them for chronic pain uh, can function surprisingly well on fairly high doses. A meiosis may occur where the pupils constrict to pinpoint size, and especially in bright light. There can be neurotoxicity, so you may see delirium, agitation. You might even see some myoclonus and other symptoms. And of course, those risk factors with that include renal impairment, um, any pre-existing cognitive impairment may worsen, and the management of that is hydration and of course dose reduction. The adverse effects from prolonged use, you can have hormonal changes, changes in periods, and there can also be altered and suppressed immune function. So what are the pharmacokinetics involved with morphine? Um, it is administered by several routes. It is not very liposoluble, does not cross the blood-brain barrier easily, and only a fraction of each dose actually reaches its analgesic action. And the problem with that is, of course, then what isn't used or metabolized can possibly be stored, and that's why our opiate epidemic right now is so dangerous, is because patients are storing it in their tissues, and they can take that next regular dose and actually OD because they weren't even abusing it because of the storage, because so not all of it is used with each dosing. There's, of course, tolerance, where there's increased doses needed to get the same response. Develops with analgesia, euphoria, sedation, and respiratory depression. There can be cross tolerance to other opioid agonists, and no tolerance to meiosis or constipation develops, though. There's also physical dependence with morphine use. There's an abstinence syndrome that occurs with abrupt discontinuation. Um, about 10 hours after the last dose, it starts with a yawning, rhinorrhea, sweating. It progresses to violent sneezing, weakness, nausea, vomiting, diarrhea, cramps, muscle, bone pains, muscle spasms, and kicking. It can last 7 to 10 days if not treated. And it's important to remember the withdrawal is unpleasant but not lethal. Patients think they are going to die, but they're not. Um, this is important to know because uh, when prescribing the buprenorphine, you do want the patient to have started withdrawals so that the withdrawals, buprenorphine helps the withdrawals um, are more, with buprenorphine, the withdrawals are more manageable. Um, if the patient is not in withdrawal and you give the buprenorphine, the patient will go into abrupt withdrawals. and still have all of these symptoms. So you want them to already be in the symptom mode, the initial reaction mode, so that you can give them the buprenorphine. You're giving them what a partial agonist so that they can manage through the withdrawals much easier uh, without going back. Because what happens is once the patient gets into the um, progression of withdrawal symptoms, they're very tempted usually to go ahead and start using again because that'll stop the withdrawal symptoms right away. So, of course, there's an abuse liability with um, use of morphine. Um, and then there are precautions, of course, with decreased respiratory reserve, as spoken about earlier, um, with pregnancy, with labor and delivery, because, of course, it can affect the baby. Um, there can be withdrawals, um, respiratory depression of the fetus. You have to be careful with head injuries because of the potential for CNS involvement and the sedation. Toxicity, clinical manifestations. There's a classic triad of coma, respiratory depression, and pinpoint pupils. Treatment is usually ventilator support, use of an antagonist such as naloxone, and then general guidelines are to monitor vitals before you give morphine to make sure that's not what's going to, that you aren't, patient isn't already on their way to that triad, and to give on a fixed schedule.